In today's episode of Sam Talks Telehealth, I'm so excited to be joined by Tim Bilbrey, the co-founder of Recovery Health Plus, a cardiac rehab home program. Now, you all love how I know taking things from the clinical space into the home, and this is a perfect example in that cardiac rehab space of how we can really make it more convenient, more user-friendly, and more in a place where patients spend more of their time their home. So without further ado, let's get straight to the podcast. Okay, well, Tim, I'm so excited to have you on the show. Welcome. Just to kick us off, let the audience know a little bit about who you are and the company that you're with.
Yeah, thank you very much for having me today. My name is Tim Bilbrey. I am the president and co-founder of Recovery Plus USA. I'm an exercise physiologist by trade. Most of my life has been spent in the traditional brick and mortar hospital-based cardiac rehab sector. And now we have moved on and ventured off into digital therapeutics and remote patient monitoring / telemedicine side.
Awesome. Well, I'm excited because, years ago, I've done work in cardiac and pulmonary rehab. And certainly we always thought about some of these things could be done from home. So as someone who, was in that hospital space and then now being digital therapeutics, remote patient monitoring, you're really one of those leaders and taking it outside of the walls of the hospital. But I think both of us, hospitals are a little adverse to change. So tell me a little bit about what has that meant to approach clinicians, whether it's the cardiologist or other, the cardiac centers in that hospital base of taking this from that setting into the home? What has been that experience?
The experience has really been kind of it's kind of been a twofold issue, because really when you look at it, the variable that really kind of pushed change was the COVID pandemic. Pre-COVID, there was a lot of, I don't want to say hesitation, but there was a lot of, well, we're in the brick and mortar facility, we're inside of a hospital, group exercise classes, scheduled, structured days. And and that's the way it's just been for decades. Cardiac rehab in a hospital has been around for several decades now, but once the COVID pandemic hit, a lot of these traditional settings, especially had a very difficult time, because you look at the social distancing, you look at possible furloughs, and then the unfortunate closure of some of these home-based, or I'm sorry, these hospital-based programs. So really where we've kind of gone into this, and especially approaching clinicians and everything else, is there is a lot more openness to it, because at the end of the day, it all comes back to taking care of the patients. Regardless of whether COVID's active, whether it's hot, whether on a downturn, or however that ends up looking, patients are still having heart attacks, patients are still having heart surgeries, and being able to find a patient-centered approach to improve what I like to call improve the accessibility to care for those patients in the home. I mean, social distancing in the home is pretty easy. So, making it convenient and easier for the patients, that was our mission. That was our goal when we got into this.
Awesome. Now tell me from the patient's standpoint, in terms of exercise, the patient may not have, a treadmill at home, and traditionally our cardiac rehab would have treadmill, and we'd also, oops, it looks like they're degrading. Maybe we call an ambulance. So talk a little bit about that, because I've heard some of that concerns from clinicians is how do we replicate the same safety level, but also that type of exercise level at home? How do you address those things?
Well, initially, it all starts with the cardiologist or referring physician in this case. Having the patient and the cardiologist both understand. The patients are going to be at home, exercising in things like that. However, the cross comparison turned into, the patient does live their everyday life. They do focus on, they have their basic, ADLs. They do have their, they go to church, go to the store, go shopping. And so really the conversation turned into, what are we kind of competing against here? And I mean it not from, one center versus another, but, being able to provide, whether it's the traditional cardiac rehab or home-based cardiac rehab, because if the patient does not go to traditional cardiac rehab inside of a facility, they're not having cardiac rehab. So the counter option, to this is it's something over nothing. And in this case, it's helping the patient, and making sure the patient's aware, making sure the safety standards, are in place. If there is some form of advanced, therapy or, needed, then we can, you can consider home health. But again, working with the referring physician and the patient to understand, when you first have the patient get enrolled into the program, it all starts with the assessment. Is the patient or are they safe? Do they, when you're able to, video FaceTime them, you're able to see the patient's living situation. Do they have access to, fitness equipment, treadmills, bike, weights? 99% of those are going to be a no. And so utilize, again, exercise physiologist by trade, to get a good, a workout. When you look at this at a home-based setting, you're not going into this approach with trying to, make these people, quote unquote, weekend warriors, to where they go in and they're just, gym muscles over functional muscles. Because what we've traditionally focused in with Recovery Plus USA is, it's functional movement patterns, it's movement training, it's balance training. While we don't have that treadmill, you do have the ability to create an exercise prescription, an activity prescription for the patient at home based on what they have access to. Do they have stairs? But then again, you always want to come into the focus of, eliminating falls, absolute patient safety, but slowly working that in with the patient. That's where, it all starts with the assessment and then seeing what we have access to.
Yeah. How do you think this, since you're really using what's in their home already or things like that, have you seen that patients actually then are more conscious all the time about their, therapy? Because if I think of a cardiac rehab setting where it's very structured, then when they go home, it might be like, whatever, I'm back to my life. Like, how have you seen those differences by actually being in someone's home and training them in a setting that they have, you're using the tools they have?
Yeah, no, and that's a perfect question, because one of the biggest, I would say, out of my 15 years in working in a hospital-based setting, two of the really big issues that we came across was geographic location. There is a very limited access of these, traditional cardiac rehab programs, because they're usually reserved for, an urban environment and inside of a hospital. And also too, then the scheduling component, because, patients have to go back to work. Cardiac rehab programs are typically open, Monday through Friday, 8 a.m. to 5 p.m. because some of the rules, some of the laws that are in place is a physician has to be either in the building or readily available, or even in some instances where the physician actually has to be physically present inside the actual rehab department. So in this case, being able to, think and be able to work that outside the box, utilize the current Medicare guidelines for, the different types of charge codes, the different types of CPT codes that are available, and understanding what those guidelines mean, then we're able to take care of patients. They can go to work, they can do it from their house. The travel time, maybe the inability to drive, and then having that piece broken out to where it's more convenient. Because when the patient's at their home, you're going to have a much greater chance of the patient being compliant, actually participating, because they can do it on their own time when they feel like they can do it.
Yeah, I love that. For a short break in the podcast, I want to talk to clinicians out there who'd like more resources and support around getting on the camera. We know you've been doing it for well over a year, but there's still some things that can always help you present just as professional as in clinic as you do on camera. So for additional resources, I've created a workshop called Camera Confidence for Clinicians. You can find that at telehealtheasy.com/camera. And that's a workshop to really help you get more connected with your patients, feel as professional in person as you do on the screen. And it's a nice workshop to be able to give you all the tools, checklists, and some really easy hacks to make it, less overwhelming to be on camera and not so worried about, I don't know, the second chin or any other variety of things. But we've got you covered. Telehealtheasy.com/camera for a great workshop on improving your virtual health visits. And with that, let's get back to the podcast. Now, you mentioned, said a little bit about the codes and the CPT codes, and obviously in the virtual care world, we're all continue to watch what, Medicare does and doesn't pay for. Obviously, the inclusion of cardiac rehab and pulmonary rehab as a reimbursable allowance from a patient's home has been huge, right? And helped move into these virtual space. As you look forward, we're all sort of in that in between. What are you thinking as an organization, as a company, of if it were to go away? Do you think it'll, it's sort of magic crystal ball? What are your thoughts at this time?
Yeah, and that is where that's where the biggest question lies when it comes to these, the home-based, facility-based cardiac rehab programs, making that leap into a home-based or hybrid cardiac rehab sector is. And just the way that I've always looked at it, most of the issues or most of the problems that I've, personally or professionally have with, any sort of barriers to traditional cardiac rehab is always been inside that, what, the definition of that charge code. And there's been a lot of efforts, a lot of, groups, a lot of hardworking individuals have gone and are trying to modify that CPT code, that billable code, because at the end of the day, if, you got to have to support a program, you have to have some form of a financially viable model for it to exist, because you got to pay for nurses, you got to pay for, you got to pay your taxes, you got to do all sorts of the things needed to be able to have this cardiac rehab program at home. So some of my, some of the things that were I found, and it's once we started focusing and moving away from that traditional cardiac rehab, billing code, we have to, you have to wait for a heart attack to be able to start exercise there, a cardiac rehab program. You have to wait for a heart attack, or you have to wait for heart surgery, or, if you have heart failure, if your ejection fraction is above 35%, you can't attend cardiac rehab. We have to, and as a clinician, it's, you talk to the patients while they're in the hospital, and you're just, your ejection fraction is 40. I have to wait for you to get sicker before I can start you in this cardiac rehab program. Exercise therapy, dietitian, vital sign measurements, medication adherence, all the fun stuff, all the really good stuff where you get the benefits of cardiac rehab. There's limitations based on, based on that, when, on the actual charge code. So what we did, and that's how we've, when we came out and created the Recovery Plus USA, we moved away from the traditional cardiac rehab charge code. When we went the telemedicine route, we went the remote patient monitoring route. We, since, I want to say since 2016, Medicare has started releasing different charge codes that are out there, because when you break down what is cardiac rehab, right? It's exercise therapy, it's, dietary consultations, it's nursing and education, medication adherence, and vital sign biometric collection, symptom management, and all of that typically has been bracketed under one code for cardiac rehab. But, on the other side, when you look at the virtual medicine side, Medicare has released multiple codes to support those individual components. And then that's where, like I said, when we as a company, we stopped billing the traditional cardiac rehab charge code, even though we provide the same basic services, the same exercise therapy, dietary consultations, biometric surveillance. We're able to support it through the increase in the rise of these telemedicine style programs.
I love it. I think sometimes, I see where you and I have similarities, is that at times when I'm working with clients and talking with people, it's like, no, let's actually look at the codes that exist and figure out if your services can match into that. So it's not reducing clinical care. It's not making less of an efficacious program. It's the unfortunate part of working in the American healthcare system is sometimes you have to just look at the giant code list and say, does this legally meet this code requirement? And can I provide that same level of care? So I love that you've done that, because that allows you to keep growing and to be less tied to, oh my gosh, what is CMS? What are the payers
Right.
going to do? Because you're using what's available. So I absolutely love that. So tell me, I always like to wrap on this question. If you could change one thing in healthcare, what would you change?
Oh boy, I would change, if there was one thing I could change, that would be eliminating the healthcare gap between urban and rural areas, because that is a very, very significant piece to this as far as the accessibility of care. Because even too, speaking with you prior to this call, it's I'm in rural Texas. I live in small town Texas, and but I've been living in the Dallas, Texas area for, goodness gracious, almost 20 almost 20 years. And just once you've been in one and you've been in the other, as far as urban/rural environments, it's completely different. And people, they get sick, whether it's in small town Texas or in the cities, or wherever it is. And that's being able to eliminate that differentiator in healthcare would be the number one thing I would support.
I love that. Yeah. And I think, and I've worked across rural for many years, and yeah, it's two totally different worlds. So I'm
It's
excited to have
two
someone
totally,
like you.
well,
Yeah, two totally addressing that. So Tim, where can everybody find you? I'll obviously put these links in the show notes, but let us know, where do they track you down?
yeah, the best way to find us is please go to our website. It's recoveryplus.health. And we have any information that anybody would want from the website. There's a form that they can fill out, and we can contact them, provide them with additional information, or even help them out however we can.
Awesome. Well, I'm excited. I think, again, things like cardiac rehab moving into the home, it's one more way that we can serve patients regardless of where they are and in a life that fits them, right? People have jobs between 8 and 5, Monday through Friday, just like the hospitals have a job at that time. So these kinds of
Absolutely.
things I think are wonderful. I want to thank you so much for joining me today, and I'm excited for people to learn more about you.
Yeah, thank you very much. Thank you very much for the invite, and it was nice getting to meet you. And until next time, I appreciate it. Thank you.
Thank you. And I hope you've enjoyed today's episode of Sam Talks Telehealth as much as I have. Don't forget to subscribe and like the podcast. That way you know when the new ones are dropped. And for all of those who want to learn more about telehealth, more resources, and have a chance to work with me directly, feel free to go to telehealtheasy.com, where you can find all the online courses and specialized services that I offer. We'll see you back here next time.